All right, presentation today on athletic training, clinical decision rules for injury assessment and intervention strategies. Okay, so introduction, types of clinical decision rules, implementation of rules in athletic training, and then future directions for research throughout the next 2 years. Okay, clinical decision rules are simple, algorithmic set of procedures that assist in diagnosis and prognosis that allow us to attempt to reduce the medical human uncertainty. They were created from patient's history, physical evaluation, and diagnostic testing results. Clinical decision rules have been seen in and utilized, recognized, and implemented by a variety of healthcare professionals, all the way from emergency room physicians to nurses to physical therapists. They, like I said, help us reduce the uncertainty in decision making, and it should not be used, it should not be exclusive, because we don't want to make it an oversimplified cookbook medicine procedure. So let's show an example of what I mean when I say a clinical decision rule. So this clinical decision rule is called the Ottawa Anchor Rule. The Ottawa Anchor Rule was invented up north in Canada. The Ottawa Anchor Rule allows us to look at certain points on the ankle and some certain criteria to see if we need to send this patient to get an x-ray or to get a radiograph. And so we're looking, and what happens is when we look at this set of criteria, let's say we have somebody that comes in with ankle pain, we can look at this set of criteria to start off with if it's lateral side ankle pain, and then we can break it down and say, all right, well, maybe they have pain over their lateral malleolus or some sort of pain on the fibular shaft. So we look at bone tenderness at A, and that'll show bone tenderness at A. So we look at what A is, and A up here says that it's on the posterior edge of the lateral malleolus, 6 centimeters from the tip. Right? So if they have pain right there over palpation, we look at that, we put a check on that box, and then we can also look at if they have the inability to bear weight, not only initially, but down the road at the emergency room. So if all of this checks out, this is a simplified rule for us to say, well, if this checks out, maybe we should go get an x-ray, right? So when we look at ankle sprains versus whether it's just a sprain or whether it's a fracture, now we have this basic rule, this basic clinical decision rule to help us decide if if this merits sending for a radiograph. All right, so that's clinical decision rules. So how can I take this concept using the emergency procedure or emergency rooms and bring it into athletic training? And what we're going to do is, in the athletic training implementation, currently there's no outstanding literature that any athletic trainers use these clinical decision rules. There was one study done up north in Ohio when I was in grad school that they actually surveyed a small sample of athletic trainers, and only 26% of all athletic trainers even use clinical decision rules. And 22% of athletic trainers said they don't use clinical decision rules. And actually those 22, not only didn't they use them, but they had no intent to use them at all. So if I take this concept of clinical decision rules and I take it into the athletic training aspect, my goal is to try and use clinical decision rule concepts and utilize what's called action research and bring it into the assessment strategy when I'm in the athletic training clinic. And when I look at my biggest issue are patients coming in and they've got a problem, and my biggest struggle is diagnosing, assessing them right the first time, so when they go away they never come back. Not because they don't like me, but because they're actually healed for the first time and they don't have a reason to come back. So we want to use something called the SFMA, the Selective Functional Movement Assessment, as well as I want to look at using the Shoulder Symptom Modification Procedure, the SSMP, to try and help develop clinical decision rules. So let's go over that. Here we have this concept called the SFMA, the Selective Functional Movement Assessment. The Selective Functional Movement Assessment, SFMA, is used to gauge the status of movement patterns related into pain and dysfunction. So we go through a proper assessment using movements that help us provoke symptoms and demonstrate some sort of limitation and dysfunction. So information is gathered by, if they can't do certain movement patterns, we know that that is correlated with their primary complaint. So let's break down this concept of the SFMA. The SFMA uses a certain scoring criteria. Either in each movement you can be functional non-painful, functional painful, dysfunctional painful, or dysfunctional non-painful. So for every movement, we're going to classify it as one of these four. Once we've classified it as one of these four, then we can break it down to figure out how we want to treat it. So let's look at all these movements. Our first movement is called a cervical spine pattern. So I'm going to take I'm going to do a normal cervical flexion, so chin to the chest, chin to the sky, and then chin rotation to the left, to the right. The second of 7 is the upper extremity patterns. So I can do pattern 1, or I can do pattern 2. And again, I'm just looking for any sort of dysfunction or normal function with and without pain. I'm classifying it down on the checklist. The next one is going into the spine, so I can do multi-segmental flexion, so I can bend down, touch my toes, or I can reach above and checking where the pelvis moves and how far my arms go back. The next 2 is the multi-segmental rotation, so I want to look behind me one way and then I'll look behind me the other way. And then the other one is called a single leg stance, where I'm just going to lift and I'm going to get my thigh parallel to the ground. And if this is too easy for them, then I can actually swing my leg to try and gain some vestibular output and some visual output and input as well. And then the last one, motion-wise, is the overhead deep squat. So heels flat, shoulders flexed, and I'm just going to basically go down and grade how well they can do a deep squat on those 4 criteria: functional, painful, functional, non-painful, dysfunctional, painful, dysfunctional, non-painful. And then these last 2 are what's called provocation patterns, which is just if they have pain with this. And these 2 patterns, horizontal adduction as well as the impingement pattern, are 2 special test patterns for shoulder impingement. So if we break this down, once we figure out if they're functional painful, functional non-painful, dysfunctional painful, or dysfunctional non-painful, that's going to tell us if the patient has a stability issue or a mobility issue. So once I figure out what their problem is, and there's more to it than just emotions, once I figure out if there's a stability problem or mobility problem, I can actually break it down into different intervention strategies. So there's the Mulliken joint mobilization that I've been attempting on some ankles and shoulders that I want to get into for stability issues, as well as there's different taping procedures. When I talk about taping procedures, I mean that it's either a taping procedure off of the Mulliken technique or just an ankle tape job or a wrist tape job. When you look at mobility, there's strain, counter strain, or PRT, positional release technique. And then there's also corrective exercise, which is a course that I'll be taking through NASM. And then lastly is pain. And pain, there's this topic called the TREs, trauma release exercises. Trauma release exercises are a bunch of exercises that cause a neurogenic response that leads to pain release. And I'm actually next week introducing it to the faculty to get them to start doing TREs, because maybe that'll fix a lot of the teachers being all upset and uptight this year. Who knows, it might work. Okay, the last thing I talked about is using what's called the SSMP, and this was developed by Lewis. It's just a different assessment strategy, using some of the same type of procedures, using an assessment process to try and reproduce pain, and from there I can try to correct or attempt to correct by introducing one of 4 intervention strategies. So I'd like to maybe look at the SSMP by Lewis to not only use in the shoulder, but see if I can develop some of my own to use in some other body parts. So to recap everything, starting off by looking at assessment, a better assessment process using the SFMA and the SSMP. After that, I want to utilize action research to choose some sort of appropriate intervention strategy, whether it be stability issue through Mulliken, or taping process, or a mobility issue through strain, counter-strain, PRT, or really attacking pain first by using the TRE method. And then after that, I want to develop some sort of clinical decision rule based upon those findings. All right, we'll run through some references. All right, guys, that's it. Have a good one.